absorbed in the circulation and cause all those side effects. And the physostigmine used only to supplement the pilocarpine. And miotics are now third choices of the drugs used for the treatment. And however, they are effective especially in case of glaucoma, and pilocarpine and is a drug to close the glaucoma in the angle closure glaucoma. So to reverse the effect of the mydriasis after refraction testing and prevention of formation of adhesions between the iris and lens, as we have already discussed, the lens and iris get adhesions, and to medically deal with this condition, the pilocarpine is used. So especially it is especially the iritis cornea under field condition, it's alternated with a mydriatic. It's used. And now we will discuss an important disease known as the Myasthenia Gravis. So I put the photo of the Amitabh Bachchan because he was the person affected with the Myasthenia Gravis but recovered after the long-term treatment. So this is an autoimmune disorder affecting about 1 in 10,000 population, and he was the one of the culprit of the Myasthenia Gravis. As indications MYA, Maya means muscle, and it is due to the development of antibodies directed to the nicotinic receptor at the muscle and plate. So the antibodies are developed against the receptor itself. So the acetylcholine cannot act on the muscles, and there will be reduction in number of free nicotinic muscarinic cholinereceptors, or the muscle cholinereceptor, to 1/3 of normal or less, and structural damage to the neuromuscular junction occurs. And this results in weakness and easily fatigability or repeated activity. And Big B, or the Amitabh Bachchan, he suffered a lot from the Myasthenia Gravis, which occurred during the film shooting of the Cooley film. And the eyelid, external ocular, facial and pharyngeal muscles are generally involved very first, and later limb and respiratory muscles get affected. This is the pattern of this Myasthenia Gravis, and we will see what are all the clinical signs of this Myasthenia Gravis. So what happens here, the motor nerve and plate, the population of nicotinic receptors available at the muscle and plate for binding with that of the acetylcholine is markedly reduced due to their obliteration by nicotinic receptor antibodies. See here, the action potential arises in the cholinergic nerves very near to the neuromuscular end plate, whereas it is going to be released. Exocytosis occurs, then the acetylcholine is released, but instead of the receptors, freely available receptors, the antibodies are developed, and the antibodies will be bounded to receptor prior to the occupation of acetylcholine. So please see that the antibodies developed against the receptors, especially the acetylcholine receptors, will make the acetylcholine not to act on the particular type of the receptor. So acetylcholine esterase molecules located strategically at the muscle and plate rapidly hydrolyze the acetylcholine. So the acetylcholine cannot stay here for a long time, so it is getting destroyed by the anticholine esterases, acetylcholine esterases. And anticholine esterases inhibit acetylcholine esterase, allowing the same acetylcholine molecules to repeatedly interact with the nicotinic receptors, and frequency of acetylcholine and nicotinic interaction is increased. That's why so many times it is going to cause the what you call as the weakness of the muscles, especially weakness of the skeletal muscles only. And here also you can see that in a normal case, the neuron is especially supplying to that of the muscle is going to secrete the acetylcholine. It's going to open the sodium channel and going to cause the contraction of the skeletal muscle. Whereas in case of Myasthenia Gravis, the receptors are already blocked by the antibodies, and hence the acetylcholine cannot act and no muscle contraction is obtained. And here also in the synaptic cleft, you can see that synaptic vesicles, they are going to fuse together and going to cause the exocytosis of the acetylcholine, but the receptors which are present on the post synaptic membranes or the muscle, this is a skeletal muscles, they will have the antibodies, already preformed antibodies, and the acetylcholine cannot act on the muscle fiber. That's how the mechanism is explained. And here also you can see that the action potential arises, then the calcium entry occurs, then exocytosis is there. In the normal what you call as the cell, the receptors will be activated with the action of the acetylcholine, and then what you call as the in the myasthenia gravis, what happens, the blocking antibody to this particular receptor will be there, so that the acetylcholine cannot compete or cannot bind to that of the receptors, and the muscle contraction will not occur. And the acetylcholine, which is freely available in the cleft, synaptic cleft, is destroyed by the acetylcholine esterase enzymes. So, because of this thing, the thymoma in the conditions like the thymus cell, then affection, the beta cell, B cell activation and autoantibody production will be there, and the antibody means the antibody developed against the tissue of the self, and it is considered as foreign. Then the symptoms of the myasthenia gravis are like this: eye muscles drooping of one or both eyelids. It's also known as the ptosis. Ptosis means drooping of one or both eyelids. Here the drooping causes are ptosis, and double vision, or it's also known as the diplopia. And face and throat muscles altered speaking. In case of the altered speaking, the tone and other thing of speaking changes. It's also known as the dysarthria, and difficulty in swallowing, dysphagia, and the problems of the chewing because of the muscles, especially the jaw muscles, are going to be affected. Limited facial expressions. So all this, the facial muscles are not under the control of your own. Then neck and limb muscles, weakness in arms, legs, neck and fingers. So many times you cannot what you call as the fold your own fingers if you are affected with the myasthenia gravis. And weakness in the chest muscles and sometimes occurs. And this service, the myasthenia crisis, may result, because whenever there is a chest muscle is affected, you cannot expand, the human cannot expand the chest, small and big, so that the aeration of the lungs will not take place. That's known as the myasthenic crisis. So here you can see in this particular person smoothing out of the forehead muscles, and eyebrow will droop down and drooping up of the corner of the mouth, especially just like paralysis. And we can see some more pictures. Here you can see that this is drooping or ptosis of the eyebrow. He cannot open, he or she cannot open the eyelids whenever such disorders are there. And smoothing up to the forehead, eyebrow will drop, and dropping up of the corner of the mouth, as explained earlier, will also be seen. And here the dropped head syndrome is known as initially the head is like this, and the person cannot make his head straight, and sometimes this is the scoliosis may also happen. Many times the head cannot be rested on the shoulder. So these are all the clinical signs of the myasthenia gravis. And the pharmacological therapy is included of the anticholinergic drugs like neostigmine, pyridostigmine, corticosteroids like the prednisolone, and the immunosuppressant like azathioprine and cyclophosphamide. They are very commonly used. And neuromuscular junction, as usual, the acetylcholine receptor is occupied by the antibodies, and the normal muscle contraction will be impaired. And the neostigmine and its congeners improve the skeletal muscles, especially skeletal muscles, and many times accumulate and act on the receptors over a longer area, whereas the treatment usually started with neostigmine 15 milligram orally for 6 hourly time, and frequently is then adjusted to obtain the optimum relief from the weakness. So the dosage requirement may fluctuate from time to time, and there are often unpredictable periods of remission and exacerbation. And pyridostigmine is an alternative which needs less frequent dosing. Then, if intolerable muscarinic effects are produced, atropine can be added to block them. So, atropine is a very specific antidote for the toxicity of all these agents. And the line of the treatment, especially in the myasthenia gravis, of course, it's explained, like the corticosteroids can also be used, the alternative line of the treatment apart from the cholinomimetics. So the corticosteroids afford considerable improvement in such causes by their immunosuppressive action, and removal of the antibodies by plasmapheresis means plasma exchange. So all these antibodies are removed and another plasma is given. And another therapeutic approach. So here it's a dramatic release if obtained, but it is very, very short-lived and can be, the thymectomy means removal of the thymus is effective in a majority of the cases, and it produces gradual improvement, then complete remission has been obtained. That means one of the very effective treatment for the myasthenia gravis. And myasthenic crisis is characterized by acute weakness of the respiratory muscles as explained earlier. And this is managed by tracheal intubation. It's a very emergency situation. Of course, the tracheal intubation and mechanical ventilation is also done. And here you can see that especially in case of this myasthenia gravis, the acetylcholine receptor or nicotinic type of the receptors occupied by the bad antibody acetylcholine receptor is occupied. Then this infusion of the IVIG causes the means antibody against this antibody, so that it will have a good antibodies against the bad antibodies. That's why the receptor will regain. And here also you can see that autoantibody production in myasthenia gravis is another type of the receptor in which the B cell is converted to plasma cell, and the varieties of the antibodies against the antibodies are produced. Antibody production, and these are going to block with that of the nicotinic antibody receptors, and the suppression of the autoantibody production will be there. And especially in case of thymectomy is done, and especially in case of respiratory muscle paralysis, we can see that the thymus gland is totally amputated, so that the symptom will permanently disappear. And the diagnostic tests for myasthenia gravis, how we can diagnose? Let's say the ameliorative test, initially edrophonium 2 mg is injected IV as a test dose. If nothing untoward actions, then the remaining 8 mg is injected after 30 to 60 seconds. And reversal of the weakness and short lasting improvement in the strength of the affected mucus occurs in the myasthenia gravis and not other the muscular dystrophies. And the provocative tests like the myasthenians are highly sensitive to D-tubocurarins, especially the persons who are suffering from myasthenia gravis are very sensitive to DTC. And 0.5 milligram IV causes marked weakness, and then, but it is ineffective for non-myasthenics. The test is hazardous because the DTC is highly toxic, but one has to use it very, very carefully. And the respiratory muscles may get paralyzed, and the test is better not for performed. And the demonstration of anti-NR antibodies in plasma or muscle biopsy specimen is a more reliable test. So nowadays it is being used very commonly. And anticholinesterases, especially the anticholinesterase poisoning, will deal a very brief about the, anyway, we are going to learn the poisoning up of these anticholinesterase agents, and extensively used. These agents are used extensively in the agriculture purpose as an insecticide. Accidental as well as the suicidal and homicidal poisoning is a very common, and local muscarinic manifestation at the site of the exposure occur immediately and are followed by complex systemic effects like muscarinic, nicotinic, and central. All the three actions will be elicited, and the symptoms of the OPC poisoning are irritation to the eye, lacrimation, salivation, sweating, copious tracheobronchial secretions, meiosis, blurring up of the visions, and also the bronchospasm, breathlessness, colic, involuntary defecation, and urination will occur. Especially these are very characteristic of the organophosphorus compound. There will be fall in BP, bradycardia, and tachycardia, and cardiac arrhythmia, and vascular collapse will occur. So the muscular fasciculations will be seen, weakness of the muscle, respiratory paralysis. It's a central effect as well as the peripheral, and irritability, disorientation, unsteadiness, tremor, ataxia. All these clinical signs will be seen in organophosphorus compounds or the anticholinesterase phosphorus, and death is generally due to the respiratory failure. Then the treatment of organophosphorus compounds are irreversible inhibitors of the acetylcholinesterases are termination of further exposure is number one. Fresh air, wash the skin and mucous membrane with soap and water, and also please do the gastric lavage and as per the need. Especially in case of the dogs and humans, this can be done, but it's very difficult to do in case of the large animals like ruminants. And maintain patent airway, positive pressure, respiration if it is falling, and supportive measures like maintain blood pressure, hydration, control of convulsions with judicious use of the diazepam can be used. And the specific antidotes for the treatment of organophosphorus compounds is atropine. Atropine is the only antidote for the naturally occurring sympathomimetic amine, the cholinomimetic amines, then the organophosphorus compounds. It is highly effective in counteracting muscarinic symptoms, but higher doses are required to antagonize central effect. It has not got any effect on the nicotinic type of the receptor, and it does never reverse the peripheral muscular paralysis, which is a nicotinic action. And all cases of anticholinesterase or carbamate or the OPC poisoning must be promptly given atropine 2 milligram per kg. Please remember the dose of atropine in organophosphorus compounds, especially carbamates or OPCs, are given as 2 milligram IV, repeated 10 minutes till dryness of the mouth or other signs of atropinization appear. That means you can give the atropine up to 200 milligram per day in a day. That means the 2 milligram IV initially, followed by every 10 minutes till 200 milligram, and continued treatment with maintenance dose may be required for 1 to 2 weeks until the complete recovery of the animal, or many times the relapse may also occur. And the cholinesterase reactivators are there, which are going to activate the acetylcholinesterase enzyme, and these are known as the auxines, are used to restore neuromuscular transmission only in case of the OPC or anticholinesterase poisonings. The phosphorylated cholinesterases reacts very slowly or not at all with the water. And however, if reactive hydrogen species then form auxines, and the generic formula is RCH and NOH are provided. Reactivation occurs more than 1 million times faster. And the pralidoxime or 2-PAM has positively charged quaternary nitrogen, and it is attached to the anionic site of the enzyme, which remains unoccupied in the presence of OPC compounds. So pralidoxime is effective antidote to carbamate or anticholinesterase poisoning like the physostigmine, neostigmine, carbaryl, and professor. And because anionic site of the enzyme is not free to provide attachment to it, it is rather contraindicated in the carbamate poisoning, especially the 2-palm, it itself become poisonous. So because of not only it does not reactivate carbonyl enzymes, it has got weak anticholinesterase of its own. That's why it is not indicated in case of the carbamate poisonings. And pyridoxine, or it's also known as 2-palm, it is slowly it is administered at a dose of 1 to 2 gram, children 20 to 40 milligram. The same can be used in case of the dogs. Another regimen is 30 milligram IV loading dose followed by 8 to 10 milligram per kg per hour and continuous infusion till recovery. And the pyridoxine causes more marked reactivation of the skeletal muscles than cholinesterase than the autonomic sites, and not all at all in the central nervous system. And as the pyridoxine is not going to penetrate the blood-brain barrier, it is not useful in the CNS science. The treatment should be started as early as possible within few hours before the enzyme, phosphorylated enzyme, gets aging. So once the time passes to greater extent, then it will never be reversed. That's called as the aging up of the enzyme. And doses may be repeated according to need. Maximum 12 gram in first 24 hours. Lower doses according to the symptoms are continued till 1 to 2 weeks, because this OPC poisoning is not a simple poison. It is highly potent poisoning and causes irreversible inhibition of the cholinesterase enzyme. The use of enzymes in OPC poisoning is secondary to that of the atropine. First, always you have to administer atropine followed by 2-palm, because the receptors need to be first blocked, then the enzyme need to be activated. So there are other enzymes like the obedoxime, more potent than pyridoxine, and diacetyl monoxime or DIAM. It's also there other than the pyridoxine, but the pyridoxine is very commonly used. And here you can see that pyridoxine iodide injection, it's available as 500 milligram, because when you become the veterinarians or the practitioners or the medicos, you need to use these drugs very repeatedly, because many times the homicides and suicides are 90% are due to the consumption of organophosphorus pesticides. So this is an antidote against organophosphorus poisoning, and the 500 milligram is available in 20 ml ampule is available, and the cost is about 175 rupees.